Everybody, welcome. I'm Elizabeth Elfenbein, the founder and CEO of Under the Sisterhood, and I'm so excited to be here tonight to celebrate the launch of Under the Hood of Women's Health with this incredible group of women and these incredible physicians and specialists, OBGYN specialists. Welcome to all of you for joining tonight's event. We're so happy to have you here. And as I said, as you join, please drop in where you're located. It would be wonderful to share that with everybody. I want to give a little bit of a backdrop about Under the Sisterhood. We're a social impact company that is all about seeing, hearing, acknowledging, and celebrating all women's voices and perspectives. It's been about being a sisterhood of women, young, old, and every age in between. And that kind of makes us intergenerational. We have a lot of conversations around that. And what we do is we get under the hood of women's individual and collective experiences, acknowledging, sharing stories and experiences to help ignite change and change for women. And so our stats are, tomorrow we'll have dropped 117 podcasts. So 3 seasons representing women from 48 countries. So all around the world. It's been fantastic. 22 Under the Hood vlogs where women share their superpowers and how they use these superpowers to support other women. And then 12 Under the Hood events. Tonight will be our 13th. We've hosted over 300 women representing over 22 countries. It might be more now. And so I'm really excited to share that. It's important for you to know our backdrop. And season 3 has been about women making the world healthier. And you look at this amazing group of women. We've interviewed over 50 women, 49 will have dropped as of tomorrow. And they represent everything from physicians to femtech founders, women's health VCs, maternal health CEOs, women's health researchers, psychologists, life coaches, Title IX experts, disease education, filmmakers, nurses, healthcare technologists, femtech attorneys, healthcare marketing experts and leaders, and professors. And the reason why I cite all of them is because out of all of these women, over 70% represent women in women's health. And a lot of the conversations and getting under the hood and hearing their stories talk so much about all of the unmet needs in women's health. That's what's inspired them to create their various companies, whether it's a telemedicine company for women in midlife, whether it's a breastfeeding company, whether it's a company to educate girls in health, whether it's a community to support women through pregnancy and within communities. The point is that it's all about women's health. And so that got me thinking and got us thinking as an organization. At the core, we've always been a story sharing platform. So what if we actually took that story sharing and really got under the hood of women's health and really looked at it a little differently? Because all of those companies I talk about focus on a very specific area. They might focus on puberty and girl health. They might focus on fertility or pregnancy or breastfeeding. They might focus on perimenopause or menopause. But we really wanted to think about it a little differently. And we saw that there's a huge unmet need. I mean, there's so much conversation about this. In particular, everybody knows what's going on with the White House, the funding for women's health research. Well, women's health is still stigmatized and considered a taboo topic. And we know that 2 out of 3 women experience some form of discrimination in healthcare, medical gaslighting. Their pain's dismissed. And when it's dismissed, it means that their diagnosis, they're usually not diagnosed properly, which means their journey's longer, which means that they're not, leading to the proper treatment. And so all of this leads to disease progression. And on top of that, women are underrepresented in research. It wasn't until 1993 that women were actually invited, not included, invited into clinical trials. So I think that's a really interesting thing for us all to sit with. But as a result, women live with conditions and they suffer needlessly for longer. And I think the other side of it is that the system has been dismissive of them from the very beginning of time, which in turn has women, they're so busy taking care of others, women have been dismissive of themselves. And I think that's really important to acknowledge. And so we wanted to create a resource space designed to address all things related to women's health from puberty to post-menopause. Our intention is to educate through authentic story sharing. I was just having an amazing conversation earlier today with another company, and we talked about authenticity, what they're doing, inclusivity, authenticity in their workplace. And, we talked about authentic story sharing and feeling like you have a safe space. And so we're going to get under the hood. We want to uncover insights, to inspire and act. If we do our jobs well, our stories will basically, raise women to question, oh my God, I think I experienced that. Let me call my doctor. Let me get an appointment. It will drive and motivate them to change. And our why, and this is a working why, it's certainly very aspirational. We want to be the place that women go for everything they need to know about women's health from puberty to menopause. Now, this is lofty, but guess what? We just launched 2 days ago. So we have 14 stories out there. If we do our jobs well, we will build hundreds of stories celebrating all of the incredible women out there, every phase of their health journey, along with the incredible physicians and OBGYNs, the specialists who understand this. And how we're going to do that is through story sharing. We know it resonates deeply with women to share stories. We always get together with our friends, and when a girlfriend tells us a story, we're more likely to take it seriously and to act. And so we know we can't compete with the WebMDs, the Mayos, what have you. There's tons of resources. We're not suggesting that we're replacing what they are, but what happens is they're often, they're so clinical, they often lack the personal connection that really is what women look for, when they're inclined to take action and respond. They want to be able to relate to other people's experiences, whether you're a new mom, whether you're a young woman going through sexual health and sexual immersion, figuring it out, hearing other stories. There's so much comfort in that, and it also inspires you to act. So we believe that by merging both physician expertise, having these incredible OBGYNs who are specialists in each of these areas, and then real life stories, we can catalyze change and empower women to take control of their health. And, I don't think it sounds lofty. These like small stories, you hear a story. I was having a conversation with an advisor months ago from the UK, and she told me a story. She's young. And she said, I was hearing a friend talk about menopause. And she's like, I'm going through all these things. And she finally went into a physician, and she found out she was in perimenopause. And she got onto HRT. And the reason why I mentioned that is because she said I would have dismissed it. I thought I was just tired. I was stressed out, all these things. That story inspired her to go take action. So we believe this is our secret sauce. It will drive women to action and self-empowerment. And so we're really excited about it. And before, I had women and physicians, but it's really girls. It starts at 8, 9, 10. Puberty starts early now, up through women and physicians who will get under the hood and use this story sharing to amplify and educate women's health issues across their journey. So that's what we're going to be about. We're really excited. We're going to get under the hood of women's stories with girls, women, and women's health stories with girls, women, and doctor stories. And these are just categories. If you're on the site at under the hood of womenshealth.com, you go in and you click, and you'll be able to get into each of the categories. You'll get to see women's stories. You'll get to see girls, young women's stories. You'll get to see the physician stories. We are not calling them patients. These are people sharing, they're women and young women sharing their stories with us, and really giving them a space and a place to have a voice to help other women. And so I just wanted to, we have a beautiful site. Our cinematographer and artist, Matt Howard Butler, created this, and I want to just play, and I hope we can hear the sound. He picked some amazing music to lay against it. And I just want to say a couple things just as a woman, not as a physician. Guys, we need our annual checkups. We need our pap smears. We need our mammograms. We need, if we're 50 and above, we need our colonoscopies. we need to be on top of that. We need our bone scans at 50. We need to take care of ourselves. We're so busy taking care of everybody else. We have to make the time and space for us. And so I'm just gonna share the pictures of our incredible panelists. Amy Danielson-Paul, our head of programming, and my co-host tonight will of course introduce our incredible panelists. I'm not even gonna say their names, so I'll let her do it in a minute. But they're beautiful here, as you can see, and they're really incredible experts at what they do. And the other thing that I think is really interesting about each of the four of them is, you know, I'm a doctor's daughter, and they are incredibly accessible. They get into the language, they get into the nitty and gritty, but they make it so we can understand it. These nuanced conversations. So I think it's fantastic, and I'm really excited. Just want to share with you, if you go onto our site under the hood of Women's Health, from puberty to post-menopause, join the global conversation, share the stories. I'm going to keep moving because we want to get into the panel. Together, we can inspire a generation of women to take charge of our health and wellness journey and embrace the vitality we deserve. So whether you're 8, 10, 12, 20, 30, 40, 50, 60, 70, this is our time. This is our time to really take action. It's never, well, maybe it is too late sometimes, but it's never too late. And so join the global conversation of Under the Hood of Women's Health. And I am going to stop sharing and hand it over to Amy.
Great. Thank you, Elizabeth. And welcome, everyone. Once again, thank you for being here with us for our monthly event. This is an extra special event that we are here for, so we really appreciate you all celebrating this moment with us. I would like to introduce our first panelist, Dr. Melissa Holmes. Dr. Melissa Holmes is a board-certified OBGYN with over 25 years experience focused on pediatric and adolescent gynecology, and she is the co-founder of Girlology. She's a fierce advocate for closing gaps in women's health by starting with girls' health. Welcome, Dr. Holmes. Thank you for being here.
Thank you so much for having me. I'm so happy to be here, and I think this is such an amazing platform to be a part of.
Thank you. I can't wait to hear everything that you have to share with us today. And now I'd like to introduce Dr. Andrea Braden. Dr. Andrea Braden is a board-certified OBGYN and board-certified lactation consultant. She is the CEO and founder of Libby, a revolutionary startup dedicated to empowering breastfeeding individuals. Welcome, Dr. Braden. Thank you for being here.
Thanks so much. I'm honored and humbled to be a part of this panel.
Thank you. And now I'd like to introduce Dr. Shiva Gafrani. Dr. Shiva Gafrani is a board-certified OBGYN practicing for over 25 years. She is the co-founder of Tribe Called V, a platform to help women learn about all of the OBGYN health issues they were never taught. Welcome. Welcome, Dr. Gafrani.
Thanks so much. I love being here, especially with all these women. Elizabeth knows and Melissa knows I love to engage and connect. So this makes me so happy.
And finally, I would like to introduce Dr. Taniqua Miller. Dr. Taniqua Miller is a board-certified OBGYN and women's health physician. She is also an empowerment coach, a midlife and NAMS certified menopause health expert, and the founder of Revival, a menopause telemedicine company. Welcome, Dr. Miller. Thank you also for being here.
Thank you again for having me, and love the presentation earlier. Really, this is revolutionary to provide this story sharing platform for women to see themselves. So very happy to be here.
Thank you. So, okay, so we're going to get on with the program. I do want to sort of explain the way we're going about doing this, because I think it's really special. Everything we're doing is about going through the life stages of what women experience. So we're going to start with puberty. We're going to go through adolescence. We're going to get into the reproductive years. We'll get into one condition. Then we'll get into perimenopause, menopause, and post, so that we cover a range of topics tonight with the experts. And so I'm going to start with Dr. Melissa Holmes. So if everybody's ready. So in your experience, and we've been having unbelievable conversations about this phase of life. Your interview on YouTube, has just been, it's phenomenal. and you've observed so many cultural shifts impacting girls' health, during puberty, both clinically and society. Tell us about what you've seen, and are there emerging trends or challenges that you believe are unique to this generation? And if so, how do you navigate these complexities and providing care?
That's a big question, but I'm here to talk about it all. First, I just want to tell you how much it fills my heart that you've included puberty in this platform, because I've dedicated my career to, as an OBGYN, spending so many years hearing women not understand their bodies and how it works. And I just decided that the only way we're ever going to change that is to start with girls. So thank you for including girls. They're left out of so many women's health conversations. So I want to just start off with that.
Girls.
Yes, yes. But, just to get to your question, as far as shifts in the health of girls during puberty, in my career, which has spanned quite a while, but even in the past decade, there have been some significant changes in girls' health during puberty. The biggest ones are an earlier onset of puberty, which I think has gotten a lot of media attention. Mostly that's breast development. The onset of menses has shifted a little, but just the general start of puberty definitely is starting earlier. And unfortunately, these kids aren't getting any education about what's happening to their bodies until it's too late. And so that is one of the cultural shifts that I think is harming girls' health. When they don't know what's happening to their body, they become anxious. And starting off your woman journey with anxiety about your body is like the worst way to start it. So that's one of the big cultural things. The other clinically significant change I've seen in girls' health is really just a massive increase in the rates of anxiety and depression and eating disorders that we're seeing. Now, certainly, I think some of these increases are because this generation is more willing to talk about it. They're coming forward more. There's greater awareness. But clinically, we're seeing actually so many more people in the hospital with eating disorders. We're seeing them at younger ages. There really are some serious mental health issues that are starting at puberty. And when you think about women's mental health, puberty is not something that you really think about mental health as much, right? We talk about moody kids. But if you really think about women's lifelong mental wellness, most mental health conditions in women start by the age of 14. And so if we can do some preventative work beginning at puberty, teaching kids coping skills, teaching them, how to do some self-care things, informing them about what to look for and how to manage their anxiety better, we can offset a lot of those mental health problems down the road. So that is one of the other really concerning clinical changes for me is seeing that. And I think I probably just went into how do you, there's my dog, sorry, it's that time. We've all got them. I think that, that's just one of the places that I have a lot of concern. I think the other emerging trend that's just the big elephant in the room is social media, right? That's the trend that scares us all. It affects us as women. And if you think about how much it affects us as women, it affects children 10 times more. They're incredibly vulnerable. It affects their behaviors. It affects their beliefs, from the skincare products they want to go buy at Sephora when they're 10 to having porn on their little iPad when they're trying to watch My Little Pony. So, our kids are growing up in a hypersexualized society. We aren't preparing them to deal with that. We think we can put blinders on and protect them from it, but really we just have to prepare them. We have to tell them, when you see this, here's what you do, because it's almost inevitable. So when I talk about, how we handle it, that's that prevention and early intervention piece that I think is really my job as a pediatric and adolescent gynecology. If I can prevent and intervene early, I'm changing the course of women's health. And that's how I navigate these complexities. And I will say that body literacy, should start when they're 2, not just at puberty, right? Because that is how they learn to advocate for themselves. That's how they learn to speak up in the doctor's office. That prevents sexual abuse. And so that is something that people can do just early on, even before puberty. So I think I kind of went into
No, you did great. I mean, you did that as an amazing, I don't even know where to pull from. There's so much to unpack there, but I think you really hit it. And I think, the reason why when I connected with Dr. Holmes was really fascinated with your approach, because you've been in practice for a number of years, but you're so, dare I say, modern, if you will, like you are so understanding of the cultural trends of today. And so I don't know if there's anything, because I know you have three daughters as well. I don't know if there was the progression or, I mean, it's an interesting thing to sort of, figure out, right?
Yeah, I mean, honestly, I think it all comes because I love teenagers. I love them. I just love them. And there aren't many people who will say that. I learned so much from them. I've learned how to talk to people comfortably about sex from my teenage patients. I have learned how to understand gender from my teenage patients, and just being open to and I know they are people, I'm calling them patients, but just learning from them in the clinical setting has really improved the way I deal with young people all around me. And I will always continue to learn from them. And I think that's the attitude we have to take.
I think that's amazing. Thank you. And we're going to, because Dr. Holmes is both our pediatric and adolescent gynecologist, we're going to go into adolescence and hear a little more. So I think this is a great question. We have some amazing adolescents and women we've interviewed, Nayara and Liz in the space who are here with us. Hi, Nayara. It's wonderful that you're here. Dr. Holmes has a lot to say about this and is pretty amazing. So I want to ask you, as adolescents navigate their emerging sexuality in today's society, what trends or patterns have you observed in their attitudes, behaviors, and understanding of sexual health? And how do you, and I know this is complex, so I don't know if you want me to give space, but how do you address the intersection of cultural influences, social media, peer pressure, and providing, the right supportive care to young individuals exploring their sexuality?
That is a loaded question, and it's taken a lot of years to figure it out. So I don't pretend that the answer is easy and that I can just tell people right away, like, oh, this is how you do it. It's so easy, because it's not. It takes time. And I will say that, I talk to a lot of parents of adolescents, and one of the things that I think parents fear is they just don't like to think about their little girls having big girl desires. And, our daughters and our girls, once they understand like how to advocate for their emerging sexuality, it's so important. And it, again, changes the trajectory of their health. When we think about adolescent sexuality, just historically, we've kind of traditionally considered like teen pregnancy and STIs to be the barometer of how we're doing with respect to sex education and sexual behaviors in teenagers. And, teen pregnancy peaked in the 90s, which is when I started practicing. And it's been steadily decreasing pretty rapidly to our lowest rates ever. And that sounds like really great news. We all like to pat ourselves on the back, like, yay, we've done that. But there's some fallout collateral that's really bad. Like, unfortunately, we've seen that, and I do say this is unfortunate because I think adolescents exploring their sexuality is important and normal. And we're seeing fewer and fewer teens having sex, maybe because they're just sexting instead of getting physical, but their relationships are changing. They're not having as much sex as their parents did when you look at the data. But in addition to that, when they do have sex, they have more STIs. They use condoms less frequently, and they have less sexual satisfaction. And that hurts me. I'm sad to hear that. And so, and the other thing I'll add to that is like rates of sexual assault on college campuses haven't really changed in several decades, as much as we've put into the efforts. So we have this massive collision between like zero or horrible sex education in our schools, which nationally it's a big problem. It's very inconsistent. It varies state to state, district to district. Nothing's consistent about it. So we have this collision between bad sex ed or inconsistent sex ed and wide open access to porn. And that's when, girls and boys are both consuming it, and they're learning how to from porn. And that's when I get the 15-year-old in my office who asked me if it's normal or if she should enjoy being choked or if she should enjoy some other porn influenced behaviors that her partner is trying to, do because that's what her partner thinks is the right thing to do. So they're kind of fed these scripts of what sex should look like, and then they wonder why they don't enjoy it. So I just think when it comes to adolescent sexuality, we just really have to change the way we teach girls about their bodies and their right to sex. That is, and I say it again, I say it all the time, understood, wanted, safe, and pleasurable. And if we can teach girls that, we're doing them a big service.
I like that closing. That's a really great ending to a very important thing. And I think that I highly recommend that everybody goes on and listens to Dr. Holmes' stories, because her stories really get into the different ways in which to look at it and stuff, like really more explicitly, really helpful stuff. So thank you for that. We're going to move on to Dr. Braden, Andrea Braden, and we're going to get into, we've gone through puberty, we've gone through adolescence, not that, I mean, it's not short like that, guys. We know it takes years, but we're going to go into the reproductive years, and we're going to talk about pregnancy. So what are your thoughts on the evolving landscape of pregnancy choices, especially considering the intersection of medical advancements and cultural norms? And how do you navigate conversations with patients about their options, desires, and the potential impact of external factors on reproductive journeys?
Well, first off, thank you for having me. It's such an honor again to be on this panel with these amazing other physicians. I think we're probably going to see a lot of overlap of themes going through the ages. And as far as the changes that we're seeing, I think you'll see them across the board. So when it comes to pregnancy, I love the word choice. And it's a really interesting time right now, because while we do realize we have more choice, in reality, it's not necessarily there. And so I think with social media, we now have a knowledge that was never accessible to women before and childbearing people before. And now they're coming to us as OBGYNs in an old, archaic, patriarchal system that many of us trained in. And, they're the ones leading the change. So here are these teenagers who are growing up, empowered. And I'd say one of the challenges is the people who are putting out this content aren't necessarily people who are trained in this field. It tends to be people who have had maybe difficulties within the healthcare system. And I applaud them, actually. I think it needs to be said. And as an OBGYN, it can be really hard to hear that we were complicit in this. And, I think back, it wasn't even 15 years ago where the landscape was very different when I was in training, and the doctor knew best. And actually our clients, the women, the people having babies, they accepted that. So I would say one of the biggest difference that I see every single day now is empowerment and knowledge, and knowing that you have choices and saying no. And what I mean by that, I work as a hospitalist, but I also work in a birth center. So I kind of see this gap developing, if you will, that women feel empowered to make choices about their pregnancy care that they didn't have before. They just picked a doctor based on their insurance company, went there, the doctor says, I deliver here, this is where you'll have your baby. If it's a high C-section rate, oh, well, that's who you chose and that's who your insurance covered. Now, I don't know if it's on Facebook groups. I'm trying to figure out where people are getting this information, but it is out there. And over again, I'm seeing people who kind of, I'd say I've heard people say they're, working the system. And actually, I think it's really incredibly impressive. And I'm like, if I were a mama bear, I would do the same thing. I think people feel that they are entitled to have the best care. And especially in this environment of, everybody knows now about maternal mortality. It's not something new. It's just out in the media and accessible and consumable on social media, and everybody's talking about it. And so now there is this fear element as well. People before, I don't think the fear really set in until you were in the hospital, and then you felt very vulnerable and that you didn't have a voice. And now when you come in, you feel more, you have, I'd say, birth plans are more common. Having doulas are more common. There's data behind this, having birth support. I think the challenge is now it's pushing up against this old system that is very difficult to change. And even as OBGYNs, many of us are struggling because this is the way we've always been. And then people are coming in and it disrupts a lot of what we're used to, maybe in a hospital birth system. So one of the great things and one of the challenges I see coming up is how do we bridge this gap? How do we, have representation in the community, let women and childbearing people know that we hear them, and change the narrative within our own field from no to why not? If it's safe, and this is why is it so distasteful to have an empowering experience at the time of birth? And it really, honestly, it took me having a bad birth experience to understand that in my own training. It's so bad that I cried every time I talked about it for a year, and so bad that it changed my entire career trajectory. And so, I think we were raised in our training, many of us, to poo-poo the birth plan, and it's ridiculous. And now being on the other side, I can kind of see this growing trend, but I think it's slow to change the system and the culture that, especially in the hospital system, it's hard to change the mindset of what we know is best. And then there are people who are accessible in the community may not be licensed in their states. They may misrepresent themselves, but they're the ones listening. And so how do we fill in that gap of helping empower people with knowledge that is evidence-based? And I think that, really presents some interesting concepts in this time of choice. You have choice, but how do you know? You don't know what you don't know. And that's where I see a lot of the difficulty afterwards.
Yeah, I think that's so interesting. I think just hearing about, being in a patriarchal system, the health system, if you will, this has been a journey for everybody. That's not, how are we going to change that? How are we going to change that? So I would imagine, the disruption for you as a physician in that environment, being able to treat your patients a certain way must have been a little scary. I think what's interesting also about Dr. Braden is she's also a breastfeeding medicine specialist and expert and a lactation consultant. So this next question, really gets into that. If it's okay, I'm going to move on. So as breastfeeding continues to be promoted for all of its health benefits, what challenges have you observed in supporting and encouraging breastfeeding among mothers, particularly in the face of societal stigmas, workplace barriers, and conflicting advice? And then, sorry to have the add-on, but how do you advocate for and empower women to make informed choices about breastfeeding while navigating these obstacles?
Yeah, so I think the next word that comes to mind, where before it was choice, I think choice kind of blends into lactation and breastfeeding and human milk feeding, but the word that keeps popping up in my head is shame. And I think there is so much shame around it being our fault for not being perfect. And I would say, I'm not sure I've ever met somebody who had a baby who is not drowning in shame at some point over feeling like a failure. And I do think this does have a lot to do with choice. And when it comes to breastfeeding or choosing to feed with your own human milk, time and time again, what I see is the shame comes from feeling like you didn't have a choice, but you're being blamed for not being perfect and not doing what was recommended. And, when I'm talking about, I talk about lactation all the time. It's my favorite topic. I am not a everybody has to breastfeed kind of person. I understand the data. And the thing that I think is misunderstood, especially among the community of people who want to lactate, is that they know, they know the data. And I've even heard this at the national level, that it's not a problem of like, we need to get the public health message out there and tell everybody that this has the best health benefits for mom and baby and society. They know. Like it's all over the place. Breast is best. It's all over the place. And still, and I would say time and again, and I bet all my colleagues here would say, almost everybody comes to us saying they want to breastfeed or lactate. So it's not a problem of getting buy-in. It is the fact that 83% of people try and only 25% still are able to make it to the 6-month recommended exclusive for best benefits guideline. There's a huge gap here. And why is that? And I think the part that's left out of the, the teaching and the education and all the messaging behind it is that we don't have support for this. We have all these best practices, and then we shame people for not being successful. And, I have this analogy. I have lots of analogies to try to explain this to people, and get them to understand the depth of this issue. Because as one of you said, maternal mental health or mental health in the adolescent years, well, maternal mental health is actually the #1 cause of pregnancy-related death right now. #1, above hypertension, above hemorrhage. It is number one. This is a huge issue, and it's very much tied into this feeling of shame, which is perpetuated by feeling like a failure at lactating. And so I think what it comes down to is we assume that, everybody who has lactating breasts can make milk. And, I like to think of it like, we're telling people to do a marathon on a bicycle cross country, and everybody has two legs. Everybody's able-bodied, has two legs and a bike. And in fact, we'll throw in a helmet for you. So everybody can get, the helmet is the breast pump. It's covered by insurance. So get on your bike. Everybody's, and we assume that everybody has ridden a bike before, everybody's had training. And then we wonder why they don't make it all the way across. And, I really think it comes down to there's so much missing in the preparation. There's so much inconsistency. I've even talked to a lot of people who struggle with milk supply, and they said, from TikTok, for example, they said, well, I really got most of my information from TikTok. They're not coming to us anymore about this stuff. They go to their peers and they go to TikTok. And, I don't blame them because a lot of doctors don't know a lot about lactation either. But TikTok can be misleading. And they said, I thought something was wrong with me because every TikTok I got on my feed said all the stuff about the abundance of oversupply. Look at all this milk that I have to donate. And nobody's talking about the 80% of people who are affected by perceived insufficient milk supply, which is not actual insufficient milk supply. It is the fear of not having enough. It is food scarcity. And it is affecting most, especially our first-time parents who are trying to do this. And so how do we expect people? I mean, the stress of that is so high. And we have all our baby list and we have our registries. And, it's, I think people misunderstand. They come in feeling totally prepared because I got my pump. I even got my extra breast pump. I got my wearable pump. I got all my supplies. My girlfriends told me what to use. And they are shocked. They are shocked afterwards when they find out that there are so many things they didn't even know to ask. And I'm sure we can all agree that even as physicians, there were things that we didn't know and we felt ashamed of because we're the doctors in this field. And, that's why I walked out on my job in residency, never come back. It nearly broke me. And I almost didn't even become a doctor because of my own shame. And I'm glad to say I've turned it around and made my whole career about it. But I felt it so deeply. And, I think it's going to take a lot of us to change that narrative and to be welcoming and make it a safe, vulnerable space for people to tell their stories and understand that it's all of us. We're all there.
Well, thank you for that. I thank you for that. And I think that's great. I urge everybody to go on and listen. Actually, we'll be dropping the breastfeeding story, but I think it's really important because I learned so much that I didn't know. I was shamed many years ago. I have adult children. I did not breastfeed, and I'm almost ashamed to even say it in this group right now. I went back to work, all the things that were put into place for me. And I knew what I knew, and discomfort, all the different stigmas attached. That was me. But what I will say to you is learning about the whole supply and demand and really understanding it. All of that will, by the way, is available. You should listen to your story. It's beyond a story. It's, expert advice, but in story, told story. So I think it's really, everybody should listen to that. We're going to move on. In the reproductive years, yes, you go through fertility, you might do egg freezing. We're going to have that in our stories. You try and get pregnant. You have different types of pregnancy. You go through postpartum, but there's so many things going on during those reproductive years. So many different conditions that pop up, from fibroids to endometriosis to PCOS, all these different things. And so I'm really excited for Dr. Shiva Gofrani to talk about her experience. She's an OBGYN in treating fibroids and other gynecological conditions. And what innovative approaches and alternative therapies have you explored to offer your patients as well? Have you explored alternative therapies and more personalized, treatment options? And how do you navigate the balance between traditional, medical interventions with holistic approaches, considering, the diverse needs of people, of your patients? And of course, their journey to healing.
Yeah. Oh my gosh. First of all, I was in tears when Dr. Holmes talked about sex and sexuality, which she and I have spoken about on Girlology, because there are so many things we could talk about just for 5 hours with that. And then Dr. Braden, hearing you talk about it also makes me teary, because as a mother of 3 and I had 6 miscarriages and I kind of tried to nurse, I didn't shame myself. I was lucky enough to have a pediatrician as a mother who really laid the groundwork for truly saying fed is best. But it actually went in a way that I I kind of like gave in, which I'm okay with, but I gave in earlier than I probably could have because of all the other aspects of breastfeeding outside of even demand and latch and everything. But I was back at work like all of us were by, 6 or 7 weeks. So even if I could have, I didn't have time. I was seeing patients. And I can't wait to hear what Dr. Miller says, because I think the common theme here is when I think about this every single day, all I can think of is in a woman's lifetime, if at worst, if all she had to do was menstruate once a month, avoid pregnancy easily, get pregnant easily, birth easily, lactate easily, go through menopause easily. Imagine if it was just that, it would still be an immense amount of work on top of everything a man does. None of it is easy. Most of us have gone through at least some, if not all of those parts of our lives, not easily. And then add to it, like you said, Elizabeth, PCOS, endometriosis, HPV, herpes, like these are the common things that women are dealing with. Add to it cancer. So this is a long-winded way of saying, I think to answer any of these questions, including fibroids, my feeling is that first we need preemptive knowledge and education, which I think that's kind of why we're all here. We really want women to learn about their OBGYN health before they've experienced some of these things, ideally. And we recognize that no one's going to learn everything all at once just from hearing about it here or on any of our platforms. But if you hear it first a little bit, I always say to my patients, if you plant a seed and you've heard me throw around words like HPV and herpes in a way that doesn't sound scary, then when your gynecologist tells you, you're not as worried. As regards to fibroids, I think you've heard me say this, Elizabeth, but I myself had ovarian cancer 8 years ago. And what that really taught me was that I love Western medicine. I took my toxic chemotherapy every single time I needed it, but I also really love integrative approaches. And so at the same time, I did some integrative approaches that really have evidence behind them, like acupuncture for my nausea, and that was wonderful. But I did some integrative approaches that didn't have evidence behind them, either because it's too hard to gather the data or the data didn't support it, but I knew they were harmless techniques. And what they provided for me, much in the field, I think also of birthing and what I encourage for my patients when they're birthing, is a sense of control. So I really think that part of, for example, the birth plan is I want to control things. So I'm going to try to control everything. If we as doctors and women and people with vulvas and vaginas could learn what are the things that I can control that are either proven or just safe enough without any harm, and they'll make me feel better so that I can actually relinquish control and collaborate with the doctors. So with regard to fibroids, that to me looks like knowledge. 70% of all women and 80% of Black women have fibroids. That's a huge number. Most people don't know that. The good news is most people with fibroids won't have any symptoms, and they were just discovered because someone had an ultrasound or a CAT scan for some other reason, or maybe on a pelvic exam if the fibroids were big enough. We know that the fibroids can cause bloating, pain, pressure, bleeding, sometimes fertility issues. Fibroids do not turn into cancer. And I feel like I need to stress that a lot because I think the big fear for people is that, oh my God, if I have fibroids and I don't treat them, they'll turn into cancer. When you hear a story where someone had fibroids and it turned out to be cancer, it doesn't mean they transformed into cancer. It means they were probably misdiagnosed at the beginning. So the burden is on us as physicians to make sure when we think something is a fibroid, to really, really prove that it is, indirectly by doing some imaging over a course of time, making sure it's not a rapidly growing mass. But again, I really want the message out there to be fibroids are common. They can cause symptoms. They don't always cause symptoms. They do not turn into cancer. And then within the realm of treatment, we could be very Western medical. We have surgery like hysterectomies or what's called a myomectomy, where you remove the fibroid or remove the uterus. We have embolizations where we block off the blood supply to the actual fibroids, leaving the uterus intact. We have increasing numbers of medication that weren't even available when all of us were training. I trained 25 years ago. We had really one very strong medication that really antagonized our hormones and made everyone feel lousy. And now there's newer iterations that are oral, they're not injectable, and they certainly still cause side effects, but they can help shrink the fibroids. And then when it comes to integrative, I will tell you one of my favorite stories, a patient that I still love to this day, that I still speak to, and I take care of her daughter as well. She had a large fibroid that was only causing some urinary pressure. And I examined her, I felt it, I sent her for imaging. We kind of proved over a short period of time that it was definitely a fibroid, nothing else. And she didn't want treatment, which is okay. There was nothing dangerous about it. She had the choice of making treatment or not. We talked about all the different approaches. And she said, I'm going to use castor oil packs. And of course, the snarky doctor in me, despite having been through cancer and doing all kinds of crazy things, I was like, all right, honey, do it. And I said very openly to her, go ahead and do it. I mean, it's not going to work, but it's going to make you feel better. Like, I'm fine with it. I'm not maligning you. I'd love for you to try it. She came back 4 to 6 months later. Now, it was at the same time that she was probably becoming postmenopausal, which may have shrunken this, but I saw with my own eyes, I felt with my own hands, and I saw the ultrasound pictures that fibroid had shrunken significantly in a short period of time that wasn't really commensurate to just the menopausal changes. Was it what she did? Was it these castor oil packs? I have no idea. But the truth is, it didn't matter. She felt better. It was harmless. And that understanding between she and I helped forge more trust in the medical community. As Dr. Braden said, all too often, doctors are like, absolutely not, even about things that are harmless. Like if a woman wants to watch one of her procedures and you know she's going to be okay with it, let her watch it. If a woman wants to take home her IUD, it might sound strange to us, but let her take home her IUD. My patient the other day wanted me to show her her tubes when I removed them at the time of the C-section. And some of the nursing staff were like, why would you let her see that? I was like, because she wants to see it and it's hers. And now she can say to her patient, her friends, you know what? Tubes are not as big as you thought they were. So I think that the onus is on us, unfortunately, at a time where we are consistently stressed and tired and anxious. As doctors, we're coming off COVID. We are still scarred by COVID just as much, if not more than the patients in certain ways, because we were acting as doctors and patients. So that said, we still have the burden. If we want to make our lives better and our patients' lives better, we have to listen so that we can also assert where we don't think it's safe for patients to kind of be overly empowered and take control over something that they actually shouldn't take control over. Let them take control over the things that are safe, and so that they can trust us with the other parts of it. So that was more than fibroids, but I think it touches on everything.
I think that's great. And I think what I ended up hearing at the end of that was really about listening. It's all about listening to your patients. And by just giving them the choice, they're empowered. So I think that's a really good thing, because the more empowered they are, the more educated they are, the more proactive they are in terms of prevention. Yes. So we don't realize these little things, nuances that we do in life that support behavior moving forward. So thank you for that. We're going to come back to Dr. Shiva. But we're going to go to Dr. Miller, and we're going to talk about perimenopause, menopause, and postmenopause. So as Amy, when she introduced Dr. Miller, she is a NAM certified menopause expert on top of being an OBGYN. And so I want to ask you, as an expert in menopause, could you provide clarity on the distinct stages from perimenopause to postmenopause, to postmenopause, so the menopause phase as well? And then how do you differentiate these phases in terms of symptoms, hormonal changes, the overall experience for women transitioning through each stage? And then I'll ask the second part because it'll be too much.
Thanks for the question. Really, I've been thoroughly enjoying, even with the chaos in the background. You don't know all of my children running back and forth like naked and with pajamas on, but been thoroughly enjoying all of this conversation from puberty. My daughter was one of the girls who talked about that experience, and knowing that there are Dr. Holmes and Dr. Bradens and Dr. Grafani's in the world, I'm just so overjoyed for what she will experience in her life. So I am a menopause specialist, and I actually came into this. It was not what I was expecting whatsoever. In fact, I remember writing one of my old attendings back in residency and saying, oh my gosh, like I'm really into this menopause. And he was shocked because he thought that I would really be into OB surgery and gynecologic surgery, was because I saw that there was just a need. Unfortunately, unlike puberty, where in my school in New York, very progressive, even Catholic school, we were separated, boys and girls. We talked. I knew what a vagina was. I knew what a vulva was. I had a lot of education. I was an 80s baby. And so, we got a lot of education before things shifted. In pregnancy, you have centering of pregnancy programs, you have all the bugs, but then it's like all of a sudden you get to perimenopause and menopause and you fall off a cliff, right? There are no workshops, there aren't groups where we can go, and it's not this transition that's really regarded as deserving of attention and care. And so to answer your question about menopause, believe it or not, the menopause is a day. It is 12 months of having no menstrual bleeding. And so you get to that 12-month mark. I have some patients, they celebrate, but they're like, it's a 12-month period. Now, if we all could say, hey, 12 months of no bleeding, and then that's it, I bet you all of the women on the call would say, that's amazing, sign me up, right? So I don't have to buy pads, I don't have to buy tampons or use cups. This is amazing. But we know that menopause is not inherent in its definition, really fails women, because it's not just about that cessation of bleeding. It is a full body transition because of all of the rich estrogen receptors that we have throughout the body that impact everything. And so for my patients, median age of menopause in the United States is 51, but the path to getting there on average is about 4 years. And for some could be 10 plus years. And that path is marred with really just like discomforts that can be so challenging for women who are going through it. And so there was a UK study, for example, that showed that 17% of women going through menopause want to quit or, in fact, quit their jobs. 1 in 5, nearly 1 in 5. And why is that significant? Because we know that women later on in life, so post-menopause and into retirement and beyond, are actually very poor. And so from a physician and someone who wants empowerment of women, we know that women tend to be more impoverished than men later on in life. Well, when 20% of the workforce wants to quit because of menopause, they're not getting that support that matters. Same too, I was looking at a small study, and it was actually pretty funny in the sense that it was 1,000 women who were divorced, and they said 70% of them said, oh yeah, my menopause, I had to get rid of him, right? My symptoms contributed to me ending my marriage. And I wonder what was going on at the time. But when we know the impact of anxiety and depression and poor sleep and lack of concentration, and really the disembodiment of who you are at your core as an individual in this human walk that we're all doing, and then not having that support, that is really what kind of made me want to jump in and offer space to this journey, because it's not just about periods stopping. And then you also have to see all of the societal influences. We're hearing a lot about menopause, right? There's this menopause renaissance that's happening. And I've been a menopause specialist since 2016. So I've been able to really bear witness to how this has shifted, but there are still people who are left on the margins of the conversation. And so right now we're seeing a lot of celebrity and it's very glamorous, and we're saying, we're not taking anymore. However, in a day-to-day office visit, most patients are not being asked when they're of age, right? When you would consider asking questions about menopause, they're not being asked. They're being gaslit. You mentioned that earlier. They're literally being told, oh, your mood is changing. Oh, you probably just need a vacation. It's the kids. The kids are stressing you out. Poor mom. You really need to go take some time off. When in fact, there are physiologic changes that are happening as her estrogen levels are declining, as her ovarian function is also declining. And so imagine going to a doctor that you trust. Now, mind you, we went through puberty, we went through pregnancy, we went through all of that early GYN. These are clinicians that have been on this journey with you, right? I've had patients that I was trying to help them not get pregnant. Then I was trying to help them get pregnant. And now here they are. They've been through the journey. I've delivered their babies. And the same too is for a lot of patients. They've experienced this with their own physician. And so for that same physician to then tell you, let me just give you this antidepressant. Oh, you need a vacation. You need to take a load off. You take that as truth. Mind you, you have lived in your body. I don't. You know when something feels different. I won't. And so my job as a menopause specialist is to, one, bring it up and to feel, or to enable my patients to feel empowered, to know that they know their bodies and that something is shifting. It's not all in their heads. There are things that we can do about it to make that journey a little bit easier.
Thank you for that. That's amazing. And it's funny because I'm not sure I want to ask the second part of the question. I almost want to ask, well, because I want to talk a little bit about this, because, I know that I was going through perimenopause, in my late 40s, and I had a spontaneous autoimmune disease come up during that. I had no idea. I was stressed out. I had everything would have been dismissive, but I don't know, this is 10 years ago, that we were even talking about perimenopause. So I'm kind of curious, because the second part of the question talks about the recent years, like even the women I'm interviewing about menopause, they're really post-menopause, but they're still experiencing the symptoms. So I don't think that women really understand that full journey, that perimenopause, you'll experience all the menopause symptoms. So do you want to talk for a minute or so about that, Dr. Taniqua?
Sure. I think that some of the earlier signs, I always tell people you might notice menstrual cycle changes, you might notice sleep disruption, you might notice irritability, but at the core of it is something has changed. You don't know what it is. Something has shifted. You might experience vaginal dryness. Why is it taking me so long to orgasm? I don't even want sex anymore. A lot of the time we attribute it to life, right? Because we do live in this very fast-paced, stressful society. And then you go to the doctor, your annual exam, which may be 10, 15 minutes, and there's so many other things to cover. And so you're not even thinking that that is what you want to talk about. And so for patients that I'm walking this journey with them, I tell them this is like kind of the new state of affairs. And there are ways that we can kind of like work it. And actually, I think of it as like this beautiful, yesterday at the conference, she said, it's your portal, right? It's a portal into a new existence. And I love that. That's going to be my new thing now, but it truly is. I also want to say that I don't think that we can move away from how reproduction and the role of women in sex really impacts how we treat menopause. Because on some level, the reason why we don't have the menopause classes is because our reproductive potential is actually ending, right? And so what does it say about a society that says the loss of youth, loss of vitality, loss of the ability to reproduce? What is our value to our society? So it says a lot that for so long, this was really hush hush, this was really taboo. It was for comedic relief in many places in media where you saw the woman whip open the refrigerator and everybody kind of got a good chuckle out of it. And so when I talk to my patients, it's like, I tell them, don't have shame that you don't know. It wasn't intended for you to know, right? Don't have shame that like, this is what you're experiencing, because 75% of women experience the same night sweats and the hot flushes that you do, just nobody's talking about it. And so for my patients who have hit the menopause, again, this is a full life transition. If it was just period stopping, bring it on, baby, but it's not. And so knowing that you will have maybe some improvement in some symptoms, but worsening of other symptoms, that's the key. The education piece, we know that the education piece and knowing what options you have, knowing what to expect is the preparation. It's kind of what Dr. Holmes said. If we can prepare our young girls to know what's to come. It's the same thing with my patients in midlife. This is what you expect. So starting at actually late 30s, I'm asking the question, because I know that for some people, it's not too early. How many people get dismissed, right, when they're told you're too young for that? My own mother, that was her story. She started with menopausal symptoms. She had risk factors for early menopause, including cigarette smoking. And so when she went to the doctor with debilitating night sweats, terrible mood changes, including anxiety and depression, although she wasn't diagnosed at the time, she was told that she was too early and she was told to lose weight. And it's not lost on me that she was an overweight Black woman, especially when you think of access and equity in terms of who gets care and who is offered with very clear cut, my periods are skipping and I'm having hot sweats and hot flashes and night sweat. That was the answer that she was given. And by age 42, she was menopausal. By age 52, she had her first fracture. And so for me, walking this journey, letting them know that this is just the new way that you are, embrace that, and then let's work with your goals on what it is that you need, especially in post-menopause.
Thank you for that. That's fantastic. It bleeds a little into our next question. So I'm going to ask you a part of it, which is really talk about addressing the nuances and complexities of perimenopause, menopause with patients, and really thinking about because of even the practice you have, this personalized treatment plans, navigating the shifting landscape of hormonal therapies and alternative holistic approaches. Like what are you thinking and doing and treating and how?
Yeah. So anyone who comes into the doors of Revival, the first question that I ask is, what are your goals? To the same point, it's not my body. As long as it doesn't hurt you, we can do whatever you want. I will give you my medical expertise, and I want to have a better understanding of what your individual goals are for what you want this to look like. What do you want this period to look like? The other big part that I want to take into account, having worked in a very traditional model, is I want to know what your life is like. I want to treat the holistic you. I know the biology. That's why they're coming to me as the MD, the letters behind my name, but I want to know all of you. Where are your stressors? Are you a caregiver? Are you launching children? Are you raising little children? Are you having new health challenges? Because all of that will play into how you experience and how you're walking through this journey. And that helps me then bring in my colleagues, because I don't believe that perimenopause is just like go to the doctor, like one doctor and that's it. I believe that this is a team approach. I'm an entrepreneur. I would never try to do this on my own. Yet I feel like so many of us were told, go to the doctor. Like Dr. Braden just talked about, we have care teams now for obstetrics, right? We have our doulas, we have our lactation consultants, and we know that those are the teams that help us have as much success as possible. And so I don't want to just know biologically, like, okay, tell me physically what you're experiencing. I want to know what is going on in your life. Tell me, because I want to equip you and like kind of like prop you up with support so that we make sure that you're going to get through this transition, because that's what it is. It's just a transition, but in the best way possible.
Well, thank you for that. Again, I know I keep pointing to go listen to the stories because I'm very mindful of time. But Dr. Taniqua's story in the perimenopause section is phenomenal. It really gives you an end-to-end on the thinking and the experience of this phase. And I urge all of us, I'm postmenopausal, so it's very helpful to learn about this. Am I too late for this? Am I whatever? But it's interesting to hear about it and to be armed and to know. And so we have a last question before we get into our rapid fire. And this is for Dr. Shiva. And I think as a thought leader in OBGYN health, you undoubtedly encounter diverse cases and issues spanning the spectrum of women's health. And in your experience, what are the most pressing challenges or misconceptions you've observed in the field? And how do you envision addressing them or debunking them to advance the standard of care? Furthermore, do you see your role evolving as a proactive advocate for women's health in this ever-changing landscape?
I mean, it's a broad question. I think that all four of us here probably see our roles changing or having changed already. We probably all thought we were going to be traditional doctors in the office all day and then, work for decades and be exhausted and love it and sometimes hate it and then retire. And yet we've each engaged in entrepreneurial efforts because I think we realize how much we each love being with patients and we love engaging with patients, but only being able to do it one-on-one without the education piece makes it impossible because people need knowledge. And again, as I joke, I talk fast and I talk a lot, but there's no way I can get everything into these 15 to 20-minute visits that are insurance-based, and I'm still in a practice where we take insurance. So I'm glad that I see my role changing and being able to kind of educate broader groups of people through social media, through platforms like this, while still taking care of patients in my office. I think the first question you had asked about what do I see as the biggest challenge, the truth is I always joke that the great equalizer among women, and I put great in quotes because there's nothing great about it, but the great equalizer is no matter how educated you are, no matter your access to care, you don't learn about your OBGYN health. We could have the most educated physician that we all know who is not an OBGYN. They have not learned their OBGYN health, right? Like we all have colleagues who are cardiologists and internists and endocrinologists and everything. They didn't learn their OBGYN health, all the way down to the least educated, someone who doesn't speak English, someone who has access to care because of problems with, their biases, the biases that have been put against them. And so that's a terrible thing, but it affords us a somewhat equal playing field with regard to the information we have to export. It has to be given to every single woman and every single person with a vulva across the board, but it needs to be distributed differently based on different equity issues. So clearly in the Black and brown population, or the Black and brown population who have insurance versus don't have insurance, the white population who have insurance, who don't have insurance, the white educated population and the Black educated population who have insurance, but don't have time to go to their doctor because they're in C-suite positions, they're physicians, they're lawyers, right? So there's so many different reasons why women don't get access to going to the doctor. And as we talked about here, we have so many more potential issues than men. So what we really need is a different healthcare model, which makes me sad. But the fact is, until we have more time with our doctors and our patients are going to be frustrated. And there's going to be this antagonism, which is going to continuously lead to women feeling like they have to go elsewhere. And the truth is, elsewhere tends to be integrative or groups that, while I love them, some of my closest friends are integrative physicians and naturopaths, and I think there's a wonderful role when done well. but there's also a role to kind of take advantage because they can very easily say, oh, those doctors are not listening. They're gaslighting. It's patriarchal medicine, all of which is true. But it's not really true because doctors want to necessarily do that. Most doctors want to go into it and have the time. Like all of us here want to have an hour with each patient. I want to have an hour pre-pubertal and then during puberty. And then right before you decide you want to have sex. And then once you've already had sex. And then before you want to get pregnant. And then while you're having your miscarriages, I want an hour at least with each of these topics. And that's not the way our medical system works right now. So my best advice to patients, which is a challenging thing to do, is make multiple visits with your doctor. And I recognize how still truly privileged that is, whether it's privilege of resources from a financial perspective, resources of getting a babysitter, resources of getting out of your work. But if you just go in for your one annual exam a year, there's no way for your doctor to be able to give you all the information that she can. And then you will be left more anxious, more filled with shame, more confused. And every single thing we talked about, from puberty, sex, birthing, lactation, menopause, fibroids, all of it is going to feel worse and is actually going to be less healthy. So that's a terrible piece of advice in a way for me to say, like, go back multiple times, but it's kind of the only piece of advice I have, unless you can afford to see many of these really wonderful concierge doctors who are doing it, but not everyone can afford it. So that's my 2 cents about all of it. I'm hopeful because now there's more information out here, but it's a problem with the insurance industry, to be fair.
Yeah, no, I couldn't agree more. And that's what we've sort of been, well, we all know. And a lot of the conversations I've been having with physicians is really talking about the women's health is so broad and so deep and it's so nuanced. And yeah, and so I think that we forget that. And I think that that's what we're trying to do with Under the Hood of Women's Health, not to do a self promo for the company or anything, but if we can get all of the stories and more and more and more and more stories we're providing, we become like a companion to providers who don't have more than the 8 to 15 minutes to see their patients. I mean, my stepmother sees 30 patients a day in her, in her clinic. She's a nephrologist, 30 patients. She's 80, 30 patients. It's not possible to have nuanced conversations. So I think that's something to be really mindful of. And we all, interestingly, every one of the physicians here each have their own businesses, and everything will go out. They each have whether it's for girls in puberty and adolescence, girlology, whether it's Libby for breastfeeding, whether it's Tribe Called V for women's from pregnancy through breastfeeding through a number of women's health issues, and whether it's telemedicine for women in midlife. All of you are entrepreneurs doing amazing things to help educate women at each stage. So I'm going to conclude my part in this and hand it over to Amy to do a Q&A and then to invite our another speaker to jump in. And yeah.
Thank you. Yes, I'd like to introduce Dr. Barbara Ensua. Dr. Barbara, she provides cancer screenings and exams for women in Ghana, and we'd like to hear about some of the services that she provides for cervical screenings and cancer screenings down in Ghana. Hi, Barbara. Nice to see you again. Barbara is also part of our board at Sisterhood, and she's a very active member of our Under the Sisterhood community. Thank you for being here, Barbara.
Thank you for having me. It's been wonderful talking about women's health. I'm a family physician, family medicine physician, and I have an NGO which works in Ghana, West Africa. And we are into education and then women's health. And about 4 or 5 years ago, I started writing a book on women's health, just for anybody at all, whether they are in a developed country or in a low or medium income country. And I decided to do a little bit of research of what is happening, because I was working here in the US, and when it's time for a pap smear, you just send a lady her postcard or whatever, and she's ready to come for her pap and to also go and do her mammogram and DEXA scan. But what was happening in developing countries was my question. And so what I found out as I did my research was that gynecologists in developing countries and family medicine physicians over there, they are so busy putting out fires, real hot fires, like huge fibroids, 20 to steady weak fibroids and, treating cancers and so on. So when it comes to screening women for cervical cancer or breast cancer, that was kind of very low on the totem pole. So I decided to kind of get involved in that area. And so for the past 4 or 5 years, what I've been doing is that we go to screen women in Ghana for cervical cancer and breast cancer. People cannot afford the mammogram, so we do clinical breast exams. And the exciting thing these days is that there are mobile devices that are being used all over the world, especially in countries where mammograms are expensive, or stationary colposcopes, which are within a clinic setting. So what we do is we take the screening to the women, whether it's in the marketplace, and you can just imagine a market in a developing country. We find a room there, we have mobile beds, we have mobile colposcopes, we have mobile thermocoagulator. So see and treat. So if we see a lesion and on a person's cervix and it's not cancer, but it's a pre-cancer lesion, and we all OBGYN and family medicine physicians know that between getting from normal pap or normal, cervix to cancer, cervical cancer, it may take 15 years. So when you're able to catch the pre-cervical cancer lesion and treat it, then there would be no need for the woman to end up with cancer 10 years later. And so we do see and treat. And then what we do is that we do not do a pap smear most of the time. That's very expensive. There are methods called visual inspection with acetic acid, which is basically vinegar. So that is used to paint the cervix. If the cervix changes color, then we know that there's a problem there. And we can treat it with a mobile thermocoagulator. And so these are some of the exciting things that are happening in the developing world, where either the countries cannot afford mammograms for people to go there, or they don't have the staff, or the women are so busy taking care of their children, trying to make a living in the to help take their children to school and all that. And so they will not get up normally and say, hey, I'm going for my well woman exam. So we take the screening to them. And that is what we've been doing the last few years. And it's been fantastic, because the other thing too is that mid-level providers like nurses and midwives and LPNs, they are being taught how to screen women for cervical cancer using the vinegar method. And they are also being taught how to treat with mobile devices like the thermocoagulator. So I think it's very exciting that there are other ways women in other parts of the world who don't have a system like we do in the US, but they have the opportunity to be screened out there. And of course, education comes before the screening starts, and so on and so forth. So I thought I would bring this in and let people, at least who are not aware, that we are very fortunate and privileged here in the US, but then the women out there, in terms of their screening for cervical cancer and breast cancer, very exciting mobile devices are being put on the market to be used to treat these women.
Thank you, Barbara. Thank you so much. And thank you for the work that you're doing. It's so important in developing regions to bring these resources to women everywhere. We'd like to open this up now to a short Q&A. If you have a question for one of our physicians here, please drop it into the chat. I can read it over here, or you can raise your Zoom hand, and then you'll come up to the top of my screen, and I can call you into the space. So any questions here for our physicians? Lucia. I see you waving. Unfortunately, you're in
Because
my
I was looking
right.
down at the widgets and I couldn't figure out how to raise the hand. So,
That's
all
all
right,
right.
because I did the old fashioned way. This has been really informative and inspiring and helpful and like not just fuzzy stuff. And Elizabeth knows how I feel about that. So thank you. And I love all of you. I really I love you. And my question is that I've been in perimenopause for so long. I'm 53 and like my period was slowing down. And I'm like, okay, good, it's gonna stop. And every once in a while I'd skip one. I'm like, okay, good, I'm gonna get there to menopause eventually. And then they started me on that really low dose estradiol. Am I saying it? Anyway.
Estradiol.
Like, okay. And so like, oh no, but now it's like back really, really reliably every month. And so now I feel like, okay, I guess I'm supposed to stay on that because it's a good idea for a lot of reasons. But now I'm like, is it ever gonna stop? Like I'm 53. Is it ever gonna stop? That's my question. Is it ever gonna stop?
So they're probably pairing it with the progesterone. And so anytime you're giving back estrogen, you have to kind of prepare it with the progesterone to protect the lining because estrogen is indiscriminate. While it's going to help with the hot flashes and everything, it's also going to stimulate the lining. So
it's just an insert. It's just a tablet. I don't have hot flashes. I don't have any of that. And so I just feel like, okay, so now it's just going to keep my period coming.
No, so probably what's happening, especially when you ramp up, is that you will get a little bit of a slight increase in your systemic estrogen, and that might be enough to kind of like trigger something. But with your maintenance phase, which should be like twice a week, then chances are your cycles will kind of continue to go off into the sunset. But believe it or not, age 55 is when we see 90% of people going through menopause, which means that between 55 and 60, there's still 10% that may. And so if you have available like your mom or like a first degree relative, like your mom's sister, you could probably ask them when they went through menopause. Unfortunately, for a lot of us, our moms don't know. They're like, I don't know.
My mom doesn't know either. She's a totally unreliable witness. I'm an attorney.
Yeah. Or like maybe they had hysterectomy.
And they say it was fine.
They may not know. Yeah. And they're like, oh, everything was fine. I don't even remember it.
That's
and you're
what
like,
said.
not
she
true.
Said, oh, it was like a non-event. So, but anyway, you answered my question. It will eventually, because it's only been 3 months. So, okay. Gonna eventually, like, I will get there. Because I'm like really done with it. I'm so tired of it. But okay, thank you.
Thank you, Lucia. Thank you. Thank you, Taniqua. There's a great question over here in the chat that I'd like to bring up from Crystal. Dr. Holmes, as a mother of teen boys, I'd like to and feel it's my responsibility to teach my boy about women's health so that they can be supportive and respectful of girls, women, both now and for their future partners. Do you have any advice for how to start this conversation? This is a fantastic question. Thank you.
I love this question. I am a big advocate for teaching all genders about all genders. And so we started when I started teaching puberty and reproductive health little workshops out in the community, we were gender separated, but we gradually brought everyone together and the parents were mortified. They were like, I don't think this is a good idea. This is not the way we've always done it. But the kids were absolutely fine with it. So the thing that's weird for kids is being separated by gender, especially when you've got gender diverse kids in the room, right? And so when you separate them, they're like, what are they telling her? And what are they telling them? And there's nothing that makes kids more compassionate and helpful towards each other than understanding what each other are going through. So I'm a huge advocate for teaching all genders about periods. All genders need to know about erections and wet dreams and masturbation and all of that. And so I commend you for wanting to do this for your sons. There are teens, just jump in. It's never too late to start teaching them. You can get them a book on girls' health. We have some girlology books. We have a uology book. It's actually written for like middle schoolers. But there are a lot of books out there that talk about girls' health that boys should read. And I hope that in the future, especially in our educational system, it's probably never going to happen, but at least in community settings, in physicians' offices, we just stop the gendering of sex education.
Love that. Thank you. Thank you for the question. Thank you. Dr. Holmes, how are you educating girls about weight, their overall health? It's from Becky.
I wish my co-founder, who's a pediatrician, were here. I am the OBGYN, but the American Academy of Pediatrics has gotten a lot of pushback lately because of talking about weight with girls. It is a fine line because obesity is real. Yet the way we talk about food and weight is traumatizing especially to young girls at puberty. And so honestly, we should never be talking about weight. The number doesn't matter. The only person who should be even considering weight in comparison to height, in comparison to health conditions, is a child's pediatrician. At home, those conversations shouldn't happen. It doesn't matter. And the thing about puberty that is so challenging, especially for moms who grew up with their own body image problems that were passed down by their mothers, we start saying things like, oh, let's eat something healthier. And when you say, is that healthy? Is that a healthy choice? Your daughter hears, she thinks I'm going to get fat because she wants me to eat less, so I won't be fat. And so so whether you're coming at it from a healthcare provider perspective or from a parent perspective, we just have to stop talking about weight and numbers. It's really about your body and how it feels and how it functions. So that's how we talk to girls about weight. We don't talk about weight. We talk about their bodies.
Thank you for that. We have about 2 minutes left. Any final questions that we'd like to bring forward? I'm just checking out the comments over here. Nayara says, I'm a middle school after-school counselor and I answer period questions honestly my boy students might have, and I try to be as shameless as possible with my girl students. Fantastic role modeling right there, Nayara.
I'll just say that one
Actually,
time.
I was going to say I have a question to follow that up.
I was just going to say one time in a class that was all genders, we were talking about periods, and one boy raised his hand and he goes, so when girls have this period thing, like how fast does the blood shoot out? And I just loved that question because he was genuinely curious and he was probably influenced by his gaming habits and seeing blood squirting everywhere. So we always make a point to say blood doesn't shoot out or spray out, it just trickles. So that is one way to talk to boys about periods.
But it's also good. I gave a little puberty talk to my daughter's school, and what I said to the girls is, I hope for you that you will feel less shame and less embarrassed than our generations. And I know it's not easy to say to an 11, 12, 13, 14-year-old girl, talk openly about your periods. But I really tried to get them to understand, why are we shielding the other 50% from how gross it is, or how we need to kind of own it so that they don't kind of keep putting back to us how embarrassing and how gross it is. And that's not easy. And I'm sure that most of them did not listen, but there might be one or two, and that'll start a little revolution. And I think the burden is on us as women as well to talk about all these things. I say frequently and kind of casually, throw in words like vagina and vulva, not in ways that sound vulgar, but in ways that sound factual, so that we can actually have less shame, embarrassment, anxiety, because that's what is leading to all of it, is everything is so cloaked.
Yes.
Carmela, you have your hand up.
Hello, hi, everybody. I am a 35-year veteran personal trainer and have had some experience with a couple of the topics that you all have mentioned. The one of which is food and teenagers. I had a very special client early in my career whose mom I had been personal training, and the mom brought her to me and basically was like, fix her, she's anorexic. And I brought her in and we started our little relationship, and long story short, I hired her to do some office work for me. And then eventually, as we got more familiar with one another and she trusted me, I asked her about her patterns, and she said, well, I never thought I was anorexic until my mom took me to a psychologist who told me I was anorexic. And then I started living like I was anorexic. So which comes first, the chicken or the egg? And I asked her if she would be willing to form a support group for her peers and other clients I had with teenage girls. And we did that for a while. And she's grown into a beautiful young lady with a daughter that's like 8 years old now, and she's perfectly fine. that's one of those things. The other example is a young boy I had. He was 8 at the time. Parents brought him to me. And when he was trusting me, I asked him about how he felt about his body and what was going on. And he said, my mom took me to the doctor and the doctor raised my shirt and said, you're fat and this needs to go. So, I mean, those are just like a couple of examples of what fundamentally is so wrong with this picture and our kids and our girls. And I think, I mean, for the most part, we have to somehow get to the moms so they can intervene, because the kids can't. The young women cannot. They're not going to confront their doctor in an appointment. So I hope that somehow in this initiative, we can get a bunch of moms on board so they can listen to you all and be really empowered. Thank you.
Thank you for that, Carmela. Thank you for sharing.
I just have a quick thing I want to add. Everybody should go on and listen to Dr. Holmes' story, because she addresses that, which is really changing the conversations with parents. So I don't know if you want to speak to that I know that we're over time, so I don't want to, but I think it's a really good thing because you address that head on.
We do. I mean, one of my priorities is helping parents raise daughters who are more empowered and can advocate for their health and around all of these health issues that we've been talking about. And everything is available on our app. That's my service, but we also do, which it's a membership thing, so it does cost. We try to make it accessible through our nonprofit, which is the Period Education Project. But I also see a question about books. I mean, there are a lot of books out there. Google will tell you what all of them are. I'm not going to self-advocate, but
Urology.
Uology is our latest book. It was published by the American Academy of Pediatrics, and it's Puberty for All Genders. But I just think talking to parents is really how we break this cycle, and helping parents. And as we educate girls and their parents are present, it changes that whole dynamic, and the parents learn just as much. So yeah, parents are very important.
Well, I know that we're very over time, so yeah. So I just thank you, Amy, for that. This has been. I don't even know what to say. I'm overwhelmed. This conversation has been amazing. Thank you so much, everybody, for attending. But thank you to our incredible panelists and esteemed OBGYNs and specialists, subspecialists, all that good stuff. You really brought to light, you shed so much light, and please go on to underthehoodofwomenshealth.com, listen to the stories. We have a YouTube channel with playlists. Share the stories. Your fellow women, your fellow sisters, your daughters, your mothers, your friends, your colleagues, everybody needs to hear these stories. We help each other. So, so thank you so much for coming, and thank you again to our incredible panelists.
Thank you.
Thank you.
Thank you for doing this.
Oh, thank
Elizabeth, thanks so much.
Thank you.
Thank you.
I don't want to say goodbye.
Until next time.
We'll be in touch.
Go for dinner. Anyway, thanks everybody.